Good afternoon, everyone. Happy 122nd Philippine Independence Day celebration to all. Philippine Independence Day was celebrated yesterday, but in the Filipino American Health Forum, we're celebrating it today. I hope you had time to ponder the significance of the event as it applies now in our lives as part of the Philippine diaspora and the quest for justice and equality in our communities. I'm Dr. Romel Rivera, President of the Association of Philippine Physicians in America, APPA, one of the organizers of the Filipino American Health Forum on COVID-19. I will be your MC today, but first let me mention my co-organizers of these webinars. We have Dr. Marie Ortaliz, President of PNA New York, Dr. Emerson Iya, Chair of Kalusugan Coalition, Dr. Laura Garcia, New York Chair of the National Federation of Filipino American Associations, or NAFA, Dr. Angelica Razon, Committee Chair of the Council of Young Filipino American Physicians, or CFAP, of the APPA, and Dr. Antonio Moya, Committee Co-Chair of CPAP of APPA. Today, we are presenting to you series number 8 of COVID-19 in healthcare workers. That's the first topic. And the second one is post-ICU syndrome. Ambassador Cristobal is a strong supporter and a partner of the Philippine American Health Forum on COVID-19. Ambassador.
Thank you so much, Dr. Rivera, and welcome, my dear friends, to the 8th episode of this wonderful Health Forum series that, to tell you honestly, people come back to us giving their feedback on the forum and how useful and how thankful they are that we are having this. Today's topic is so very, very important because yesterday, as we celebrated the 122nd anniversary of the Philippine Independence Proclamation, we had the focus on our healthcare workers, the frontliners in the current fight against COVID-19. And so the forum we had last Saturday that featured first-person testimonials from 3 of our frontliners was an excellent start for the first part of our discussion today. COVID-19 in the healthcare worker community itself. But I am so very interested in the second part of today's forum, post-ICU syndrome. You know, whenever I am no doctor, never got any big and deep science background. Well, economics is science, but the small science they call it. But whenever I hear the word syndrome, it gives me the chills. So is this a malady separate and distinct from COVID-19? So it's going to be a wonderful time to be learning more, just as we've been learning the past 7 times from this wonderful series. So welcome again, Dr. Abiad, Dr. Celi, to this forum, and we look forward to your presentations.
Thank you, Ambassador. Before we go any further, I'd like to call on Dr. Angelica Razon to give us some medical disclaimers and housekeeping rules. Dr. Razon.
Our goal for this series is to build community and share information. If you or a loved one is having a specific medical concern, please seek attention from your healthcare provider. This is an evolving phenomenon, and every locality situation is different. Please refer to cdc.gov, coronavirus.gov, and your local public health department for the most up-to-date information. Thank you, and I'll return the microphone to Dr. Abiad to continue the rest of our program.
Thank you, Dr. Razon. At this time, I would like to call on Dr. Antonio Moya to introduce our esteemed speakers. Dr. Moya.
Thank you very much. I have the pleasure of introducing our two speakers today. First, we have Dr. Homer Abiad. He is a graduate of the University of the Philippines College of Medicine. He did his internal medicine residency at UMass Memorial in Worcester, Massachusetts, and his infectious disease fellowship in the combined program of the University of Illinois at Chicago and the University of Chicago. He has a master's in public health from the University of Illinois at Chicago. He is an infectious disease specialist at John Stroger Hospital at Cook County, formerly known as Cook County Hospital.
Magandang hapon po sa inyong lahat. I'll see a while. I am sharing my screen here. The COVID pandemic, as we all know, began in Wuhan in China, and for much of the world, the face of COVID in healthcare workers is that of Dr. Li Wenliang, an ophthalmologist there who sounded the alarm at the beginning of the outbreak. He was silenced by authorities before himself becoming infected and dying from COVID on February 7 at the age of 34. So how often do healthcare workers like him come down with COVID? As of late February, over 3,000 healthcare workers in China had been diagnosed with COVID, which represented about 4% of all cases there. By April, 23 of them had died. The vast majority of them were physicians, and all of them had been admitted in January and early February in the earlier phases of the outbreak, just as it was being recognized. And this is a natural pattern that we see in other countries as well. The next global hotspot was Italy, where the healthcare system was overwhelmed with tragic results. Healthcare workers there were infected at a much higher rate than in China. And by mid-April, close to 17,000 of them had been infected, and that was a full 10% of all the cases there. At least 206 of them died, and of those, as you can see here, almost 60% were doctors. And of the doctors, the vast majority were general practitioners. These were mostly elderly doctors who were brought back out of retirement to battle the epidemic, only to become casualties themselves. From Italy, we turn next to another country where doctors were among the first casualties early in the epidemic, and that is our home country, the Philippines. The first case there was found on January 30. And in late March, there was like a steady stream of reports of doctors becoming severely ill and dying from COVID, including several who taught me and Dr. Celi in UPPGH. As of early this month, the DOH there had reported that over 2,000 healthcare workers in the Philippines were diagnosed with COVID, which represented about 14% of total cases there. With a total of 32 deaths. When we think about healthcare workers coming down with COVID, we naturally tend to think about them getting it from their patients, but that's not always the case. This analysis of 110 healthcare workers from Wuhan, an estimated 60% got the virus from the patient, but in 11%, the infection was actually from a colleague. And in 13%, the infection actually occurred outside the workplace from family or friends. Okay, what about here in the United States, which holds the unfortunate distinction of being #1 in the world in COVID cases and deaths? As of earlier this week, the CDC reported that a total of 71,000 COVID-19 cases were diagnosed among healthcare workers, with 371 deaths, but this is clearly an underestimate. Perhaps a better estimate of COVID in healthcare workers here comes from this report from Kaiser Health News, which as of last week counted 586 deaths in healthcare workers from COVID-19. The cases are still being confirmed and collected in a database that will be released later this summer. So for now, we don't have a lot of details about them, although the report does say that the majority of these deaths occur in two groups, African Americans and Asian Pacific Islanders. Everyone, of course, in this forum, in the audience, knows who these Asian Pacific Islanders mostly are, and they are our Philam healthcare workers. There are numerous reports in the press of Philam frontliners in the U.S. who have died from COVID, but there really isn't a good tally of them. The Asian Journal in mid-May quoted Ambassador Romualdez as saying that 40 Filipino healthcare workers in the U.S. Had died of COVID that they were aware of, but the number is undoubtedly higher than that. One factor that could lead to a high number of Philam healthcare workers with COVID is just where they are located. Filipino nurses make up just about 4% of nurses in the country, but they are concentrated in certain areas of the country, including the New York City, northern New Jersey area, which we know is obviously the area hardest hit by COVID in the U.S. Let's turn now to what we do to prevent healthcare workers from being infected with COVID-19, our infection control measures. There are standard and transmission-based precautions, primarily good hand hygiene and the proper use of personal protective equipment, PPE. There are also measures to decrease or minimize exposure to infected patients, such as wider use of telehealth, telemedicine, and universal masking. There are also engineering controls, such as placing physical barriers like those plexiglass screens in patient-facing areas, just like you see in stores everywhere these days. And then thorough and regular environmental cleaning plays an important part as well. I'll just say a few words about two measures among these that have received a fair amount of attention in this pandemic, PPE and universal masking. The PPE recommended by the CDC for healthcare workers caring for COVID patients include the N95 respirator, face shield or goggles, gloves, and a gown. The CDC had to face the reality of PPE shortages, though, recommending that face masks be used when N95 respirators are not available. Which brings us, of course, to one major problem in our response to the pandemic, and that is the lack of adequate PPE to protect healthcare workers. It says much about our lack of pandemic preparedness, deficiencies in our public health infrastructure, and inequities in our healthcare system, but that's a whole separate talk. Suffice to say that the inadequate supply of PPE has been one factor contributing to healthcare workers getting COVID in this country, but all over the world as well, in many countries around the world. Proper PPE use helps us avoid infection when it's used. We use it around patients known or suspected to have COVID. But one dangerous feature of this infection is that it's often spread by cases who do not yet have symptoms. It's thought that a full 40% of transmission occurs from pre-symptomatic cases. And that is so that even before people become sick, they're already spreading the virus. It's felt that, in fact, the highest transmission risk is in the 2 days prior to the start of the illness. As you can see in this graphic. So infectiousness is felt to peak just before the illness starts. This line shows where the symptoms start, and then infectiousness sort of gradually tapers in the first week of illness. So everyone has to be considered potentially infectious, even those who look and feel perfectly well. And that's the basis for recommendations for universal masking, which many hospitals instituted in March, and then the CDC recommended in early April for the general public as well. And to my mind, it's been one of the biggest factors in stemming the spread of infections in our healthcare facilities. Masks provide protection to some degree from inhaling infected respiratory particles, but even more importantly, they provide source control here. So when worn by the infected person, by significantly blocking the release of infected respiratory droplets into the environment. So in this graphic, the risk of transmission is highest when both the infected person and the healthy uninfected person are not wearing masks. And so you have maximum risk of transmission, and the risk is least when both the infected person and the uninfected healthy person are wearing masks. Since it's impossible to identify pre-symptomatic cases without testing everyone, we just have to assume everyone is potentially infected, hence the recommendations for universal masking, not just in hospitals, but everywhere, even out in public, in the general public. One last issue I want to touch on is when healthcare workers with COVID can safely return to work. The CDC lists two strategies for this. The first is the symptom-based strategy. Basically, they can return to work when they've had at least 3 days without fever, symptoms are improving, and at least 10 days have passed since the symptoms first appeared. The second is the test-based strategy. Basically, they can return to work when they've had at least, when their fever and symptoms are better, and you have 2 negative nasal swabs, negative PCR swabs, at least 24 hours apart. While this sounds fairly more straightforward, one drawback to this testing strategy is that there can be prolonged shedding of viral RNA, although it's felt that these are likely non-viable, non-infectious viral particles. In this study, the median duration of viral shedding was 31 days, with the longest was 48 days. So basically, in more than half of these patients, they continued to have positive nasal swab PCRs of more than a month after the onset of their illness. We also know that this shedding can occur on and off for a while after recovery, which has led to some difficult situations, like this nurse here in Chicago who got COVID, then recovered and returned to work in the hospital and was retested later on because of a cough, and one of the 2 swabs came back positive. We've learned, though, again, that these prolonged positive PCR tests seem to represent non-infectious viral particles. And so far, studies have failed to find live virus in the respiratory samples more than 9 days after onset of symptoms. So at my institution, we use the symptom-based strategy. We don't routinely retest, because if you get a positive in someone who's recovered, you feel sort of obliged to keep them off of work, even if they're likely not infectious anymore. Let me end with these words, actually the lyrics of an original song that was sung by me and my med school class in a choral contest at our school. It was composed by classmates of mine, and the lyrics are based on the Hippocratic Oath. And the song begins, bilang manggagamot, ako'y nanunumpa, sa kabila ng aking likas na kahinaan. Buhay ay iaalay upang panatiliin ang kalusugan ng sangkatauhan. I will offer my life for the health of humankind. It seemed like just a lofty, abstract aspiration in the past, but it's become a stark reality for doctors, nurses, and other healthcare workers in this age of COVID. Thank you.
And I also have the pleasure of introducing my mentor when I was in graduate school, Dr. Leo Celi. As Clinical Research Director at the MIT Laboratory for Computational Physiology, and as a practicing intensive care unit physician at the Beth Israel Deaconess Medical Center, Leo brings together clinicians and data scientists to support research using data routinely collected in the process of care. His group built and maintains the publicly available medical information mart for intensive care called the MIMIC database and the Philips MIT EICU collaborative research database with more than 12,000 users from around the world. MIMIC 3 has been cited more than 1,500 times since 2016. In addition, Leo is one of the course directors for HST 936, Global Health Informatics to Improve Quality of Care, and HST 953, Collaborative Data Science and Medicine, both at MIT. He is an editor of a textbook for each course, has released under an open access license, secondary analysis of electronic health records, which has been downloaded more than 500,000 times and has been translated in several languages. Now, finally, Leo has spoken in more than 35 countries across 6 continents about the value of data and learning in health systems.
Magandang hapon sa inyong lahat, magandang umaga sa iba, magandang gabi sa mga nanonood sa ibang parte ng mundo. I'm going to be talking about post-ICU syndrome. I work in an intensive care unit, or what we call ICU for short, where we care for the sickest patients in the hospital. There are 3 reasons why someone might be admitted to the ICU. First, they are unable to breathe and they are at risk of requiring a breathing machine, or what we call a ventilator. Second, they have low blood pressure, or what we call shock, and they need medications to artificially raise their blood pressure. And third, they might be comatose or near comatose, and they are at risk of not being able to protect their airway. That means they are at risk of aspirating food or saliva going down into their windpipe and into the lungs. Most patients stay in the ICU for 2 to 4 days before they are moved to the regular ward. This is Hugo Sosa. He spent 41 days in the ICU with COVID-19, including 19 days on a ventilator. The disease also caused a stroke. He is relearning how to stand and walk with the help of a physical therapist. He'd like to know what to expect when it comes to his recovery. Before COVID-19, one of the hottest research topics in my field is post-ICU syndrome. What happens to those who have a prolonged stay in the ICU? A common diagnosis among those who have prolonged stay in the ICU is septic shock. It's a condition where an infection elicits a deranged response that leads to the breakdown of various organs. We call this multi-organ failure. COVID-19 is an example of septic shock. The average length of stay in the ICU of patients admitted with COVID-19 is around 7 days. What do we know about survivors of septic shock? Based on these 2 papers shown here, 1 in 3 patients who are discharged alive are readmitted to the hospital within 3 months. 1 in 5 die within 1 year of hospital discharge. But even more distressing is the damage, sometimes irreversible, that results from a prolonged ICU admission. The damage produces cognitive impairment of the brain, weakness from involvement of the muscles and the nerves, and psychological sequelae. The figure here shows the degree of brain damage of patients who had no issues prior to hospitalization. And we're showing here the brain damage at 3 and 12 months after a prolonged ICU stay. The green line, the very first line there, represents normal brain function. The line below, labeled MCI, represents what is considered mild cognitive impairment. The third line represents a degree of brain damage seen among patients with traumatic brain injury. And the last line, the pink magenta line, represents a degree of brain damage seen among patients with Alzheimer's disease. Let's start with the right-hand panel. For patients 65 and older, and who had no problems with cognition prior to ICU admission, we see an impairment similar to those who sustained a traumatic brain injury. There is some, but not much improvement by the end of the year for those who are still alive. But maybe we will only see this among older patients? Wrong. If you look at the left-hand panel, These patients who are younger than 65 are slightly better compared to those who are older, but not by much. Once again, these cognitive deficits persist up to a year from discharge. But maybe if the patient is really young, they might be spared from the side effect of prolonged ICU stay. Wrong again. The first panel shows the data for those 49 and younger, and the middle panel shows the data for those 50 through 64. There's not a whole lot of difference between these two age groups. Is there a crystal ball that will tell us which patients are most likely to develop post-ICU dementia? The answer is yes. Delirium in the ICU is a strong predictor of dementia after a prolonged ICU stay. What is delirium? During illness, hospitalization, or recovery from surgery or stroke, many people experience delirium, a rapidly developing altered consciousness and an inability to focus. Most patients are confused, but there is a subset of patients who develop what we call hypoactive delirium, who become uncharacteristically unengaged. 30 to 80% of those who survive a prolonged ICU stay will have some degree of dementia, and this is characterized by short and long-term memory problems, difficulty with problem solving, and a decrease in attention span. Some may improve, but others will never fully recover. About 50% or only about 50% are able to return to work within the first year after discharge. And of those who are able to return to work, a substantial fraction are not able to return to the same job prior to ICU admission. This graph nicely shows how the duration of delirium in the hospital is highly correlated with the dementia score at 12 months after discharge. So if you had the delirium longer, your degree of dementia is bound to be so much worse. Patients who develop delirium in the hospital show changes in their CAT scans of the brain. Both these patients are in their 40s. The one to the right had delirium for 12 days, and the one to the left did not have any. The arrows point to the ventricles, the space in the middle of the brain that is filled with fluid. It is much bigger on the scan on the right because the brain mass has atrophied or has shrunken. Dementia is one of three manifestations of post-ICU syndrome. Post-ICU syndrome consists of health problems of the patient after ICU discharge that involve the body, the mind, and the emotions. The three components are, we've discussed the first one, brain dysfunction or dementia, but we also see ICU-acquired weakness and or mental health problems. Post-ICU syndrome does not only affect the patient, it can also affect the family and friends of the patients. ICU-acquired weakness would affect up to 50% of patients admitted for septic shock, especially if they required mechanical ventilation. It is seen in half of those with ICU length of stay of at least 1 week. Patients typically take more than a year to fully recover their strength, and this muscle weakness would affect activities of daily living, such as feeding, bathing and dressing, and walking. As regards mental health problems, about a third of patients would develop major depression. 10% would have post-traumatic stress disorder, characterized by nightmares, intense feelings, and clear, vivid images of their memories of the ICU stay. Anxiety disorder and sleep disorders are very common. These are measures of disability after a prolonged ICU admission. The graph on the left-hand side looks at all ICU survivors, and you could see here that they will have moderate disability at 3, and it would persist up to 12 months. The red dots on the right-hand side represents a trajectory of those with post-ICU syndrome. And as you can see here, they would have scores that is consistent with severe disability. And this would persist up to 12 months after discharge. Can we prevent post-ICU syndrome? The good news is yes, we could. The ABCDEF bundle has been shown to be an effective intervention to decrease the probability of post-ICU syndrome. It consists of the following components. A stands for analgesia. It refers to the assessment, prevention, and management of pain. B stands for both SATs and SBTs, which stand for spontaneous awakening trials and spontaneous breathing trials. This means daily interruption of sedation, daily assessment of extubation readiness. C stands for analgesia and sedation. We try to avoid a certain group of medications called benzodiazepines. An example of that is Valium. We avoid drugs with long half-lives. D stands for delirium. We also assess, prevent, and manage delirium. E stands for two things. First is early mobilization. We try to walk them even when they're still hooked to a ventilator, and we also do something about their environment. We preserve the sleep-wake cycle. We constantly orient the patient to person, date, time, and place. And finally, F stands for family engagement and empowerment. How good were we with regard to providing the ABCDEF bundle during the pandemic? The answer is not good at all. We were only able to do the first one of all the 6 components of the bundle. We were not able to do letter C at all. We were using long-acting drugs, and the reason for that is we ran short of the short-acting sedation and analgesic medications very early on because we were using a lot of them. And of course, the last one, F, family engagement and empowerment, was not done at all because the families were not allowed to visit the patients in the hospital. We therefore anticipate post-ICU syndrome to be a significant issue for those who survive COVID-19. Is there anything we can do? Yes. Before the pandemic, an area of focus is the establishment of post-ICU clinics. A multidisciplinary team is tasked to address the significant neuropsychological, mental health, physical and functional challenges among survivors of critical illness in the months and years after discharge. This is Mr. Sosa on the left with his family before COVID-19, and that's him now on the right at the rehabilitation center. Therapists have retaught him how to swallow, how to use a knife and a fork, how to comb his hair. His physical endurance, near zero when he arrived, has improved dramatically. With each passing day, he requires less oxygen through the cannula in his nose. My therapist is teaching me how to walk again, Mr. Sosa said. It is a reset. It is a true reset of learning, of getting your strength back. The hospital kept me alive, but my therapist is putting me back together. And thank you.
Well, thank you. Thank you, Dr. Celi, Dr. Abiad. Excellent, excellent presentations. And thank you so much for coming to speak for our Filipino-American community. So we now come to the question and answer section of the forum. First, I want to call on our organizers if they have questions. I think Dr. Marie Ortaliz has a question. Marie.
Yes, thank you, Dr. Romel. My question is for Dr. Celi. I have a question on the decrease in cognitive impairment and ICU delirium. What is the major contributory factor for the cognitive impairment? Is it the hemodynamic instability, or is it a combination of pressors and long-acting sedation, or just mainly the ICU environment where the patient is in, which has contributed to the patient's confusion and delirium?
The answer is all of the above. The disease itself, the septic shock affects the brain, and we saw that in the CAT scans. There is a marked atrophy of the brain for those people who develop delirium. And then, of course, the treatments that we have to administer to the patients are also contributing to this. And for that reason, this is really a big issue that we have not come to appreciate until much later on. Before, the focus is only, let's get the patient survive this acute illness. And we think that as long as they are alive at the end, that's good enough. But now we're learning that it's not good enough. There is a long road to recovery afterwards, and we need to continue supporting and caring for the patient and also his family and friends after they are discharged from the hospital.
Thank you.
Thank you. Thank you. Dr. Emerson, Iya, do you have a question for the doctors?
Yes, thank you, Dr. Abiad and Dr. Celi, for those really informative and insightful presentations. I have a question for Dr. Celi. In one of your slides, you went over the ABCDEF protocol, and when you evaluated it after or during COVID, you found out that not all of these, let's say, steps or protocols were followed. So I'm curious to get your comment as to when we look at this COVID mortality and morbidity rates moving forward, how could we relate the factors of not following the protocols and the notion of providing quality and safe care during this pandemic?
So there is a reason why we were not able to follow the protocol. Not because, well, one of the factors there is that we were overworked. We were really strained. We did not have enough physical therapists. Also, we also had to think of the safety of the healthcare workers. So we cannot really start providing as much physical therapy during the time that they were in the ICU. And the other biggest reason is that the patients were too sick. We cannot afford to wake them up because they were requiring so much support from the ventilator. A good 10 to 20% of them were requiring continuous dialysis. And of course, you cannot start to move them when they are requiring this much organ support. So we were not able to follow the ABCDEF bundle, not because we did not want to or we completely forgot to, but because the patients were too sick and they were not candidates for this intervention. I have a question for Homer before I pass it on, if that's possible.
All right, sure.
It's a bit controversial question, and I will leave it up to you if you want to answer it or not. So can you venture a guess of why in the Philippines, the proportion of doctors and nurses among those who got COVID is much higher than in other countries?
Well, it sort of depends where. It's sort of compared to, I mean, Italy actually had a much higher proportion than we did. But yeah, I think there are a lot of questions about the epidemiology of COVID in the Philippines, and it's very interesting. For instance, the fact that, yeah, it seems like there are fewer cases, at least in the lower socioeconomic classes. I mean, part of that obviously is less testing, less access to healthcare. But yeah, there, even apart from that, again, there do seem to be large differences in the epidemiology between here and there. Certainly, though, at least among the doctors, while certainly a number of the doctors that were affected early on were certainly frontliners. Dr. Makasaet, one of our professors, was an anesthesiologist, and they're obviously higher risk. Dr. Hara was a cardiologist, and he was treating a patient who had come back, who had traveled to Wuhan and had not disclosed that. But a lot of them as well got it from travel, and there were some that we know from our schoolmates who got them from conferences. And of course, these sort of international exposures are exposures that sort of the lay people sort of in the general public, of course, in the Philippines is not that does not have. But yeah, a lot more remains to be learned about the exact epidemiology, especially in different countries like here in the Philippines.
Thank you.
Yeah. Thank you. Certainly a lot of things to learn more about this virus at this point. So Dr. Laura Garcia, do you have a question for the doctors?
Yes, thank you, Dr. Romel, and thank you, Dr. Abiad and Dr. Celi, for the wonderful presentations. My question may be answered by either one of you. As health professionals, we remain true to our calling, and that is to save lives. However, though death is inevitable, it is when it comes unexpectedly that throws us all off balance. So, how or what motivates you and to get up and face another day? And how do you cope when you yourself is thrown this curveball and your own colleague or colleagues die?
Leo?
Oh, I was gonna say I guess you're going for age before beauty.
Well, you're in the ICU all the time.
Yeah.
You're
So I mean,
a lot more
personally,
depth than I am.
so personally, what motivated me to work, and I did had to do additional shifts in the intensive care unit, and I think it was actually the nurses who motivated me to come to work. You see them there, they come in every day, and they are also more at risk compared to the doctors. The nurses are the ones who are marinating in the presence of the patients. They spend more time by the bedside of the patients, while doctors would come in maybe once or twice a day. The nurses are there every hour, especially when the patients are very sick. And I did not hear a single complaint. I did not hear a single nurse saying that I'm going to call in sick because I'm scared for my life. I'm scared for my family's life. And that motivated me. Like, if the nurses are there, there's no reason for the doctors not to be there.
I agree. I mean, it's certainly, especially early on, say like early March, when we knew it was that the epidemic was starting in this country, and we were watching what was happening first in Italy in the ICUs there, and then in the emergency rooms of New York. And the question is, like in Chicago, just like, oh, is this going to happen here too? And it sort of became almost like a battlefield mentality, and what might be coming, we're sort of preparing for the worst. But that as well, sort of as mentioned by the frontliners last week in last week's forum, it was sort of a crucible, and that sort of helped the healthcare teams really come together, everyone stepping up, and sort of makes you realize again why you're in the healthcare field, and to take care of people, and what greater need is there than in a pandemic like this, where there's such an excess of morbidity and mortality, and particularly because there were so many unknowns, and there still are so many unknowns about this infection. But a lot of it was really just teamwork of people coming together and realizing what needed to be done, what extra work needed to be done at personal risk to themselves, and just stepping up. And it's really been inspiring to see all that.
Thank you very much.
Thank you. Dr. Razon or Dr. Moya, do you have questions for the doctors?
Yes, I have a question. I guess thank you, Doctors Celi and Abiad, for sharing your expertise with us today. And I guess building on the themes that we were just talking about, and also building upon the themes that during our Frontliner Forum we discussed, I guess I wanted to talk about kind of the culture of healthcare and those of us who are providers. Dr. Abiad, you had mentioned during your talk that especially during the early part of the pandemic, there was a lot of issues with our public health infrastructure, and we had to learn very quickly about how to respond to such a disaster. And I guess I'm also wondering about what have you learned, or what have we as a society has collectively learned about the culture in healthcare? I think a lot of us go into healthcare because it's a calling, it's a vocation. But I guess I might be guilty as one of the many providers who's like, I'm not quite feeling so well, but I have to go to work and I have to take care of my patients. So I'm wondering, like, if either one of you could comment on what we've learned about that and what kind of might need to change in our healthcare system kind of going forward.
That covers a lot of ground there, but certainly to begin with, like for specifically say what you mentioned in terms of I think for most healthcare workers that was always the case. You don't want to call in sick just because you have a tickle in your throat or what might be a mild cold. And certainly in the past we could get away with that, but certainly now it's sort of been something we'd really have to drum into our medical staff because often enough the infection can produce very mild symptoms, and as I pointed out, even before the symptoms, you can be infectious already. So really paying much more attention to staying home when you're ill, and that's been a big change. I think it's certainly been a wake up call to all our institutions in the past. Back which H1N1, there were all these pandemic preparedness drills, and we sort of went through them sort of just as an exercise, but I guess none of us having lived through a pandemic before, it was sort of a very academic. We had a little more sort of when Ebola came, but sort of it never really came to these shores except for 1 or 2 cases. So really, I guess that frame shift where we realize these things happen and they probably will continue to happen, and we have to take pandemic preparedness seriously. And then lastly, I guess sort of in the past, it's always been dedication, and certainly it's hard work, and sort of dealing with death and illness of patients has always been a stress, both physically and mentally, on healthcare workers. But I think the different thing about this pandemic is, again, it's sort of at the personal risk to ourselves because of the infectious nature of it, and because even especially early on, we weren't exactly sure how infectious it was and how it spread, and we're continuing to learn about that. But that sort of, even as the frontliners pointed out last week, part of it is the difficulty of dealing with all the death, but part of that is the fear, the personal fear of getting it or bringing it home to your families, and what every day might bring. So it's really, I think, made all of us sort of think long and hard, but I think appreciate as well our role as healthcare workers.
Thank you.
So one of the silver lining, I think, of the pandemic, especially here in the United States, is that suddenly the nurses, the doctors, the therapists, the pharmacists, we became the face of healthcare again. Prior to the pandemic, the face of the healthcare is the pharmaceutical companies, the insurance companies, and there's so much mistrust of healthcare because of that. But we've never experienced such such gratitude from the public. I think people are aware about every 7 p.m. in New York City, they will produce all these sounds. They will honk their horn in appreciation of the frontline workers. So to me, I wish that this will continue on, that we become permanently the face of healthcare and not the insurance companies and the pharmaceutical companies and the healthcare CEOs. So I think that is one of the best cultural changes that we've seen as a result of the pandemic.
Well, thank you.
Great.
Moya, do you have a question?
Yes. The question is for Leo, and I also have a question for Dr. Abiad. But regarding the ABCDEF bundle, so much of a patient's journey that's not talked about is the rehabilitative stage of their disease journey. So for Filipino families and communities specifically, what exactly is family engagement and empowerment, and what kind of cultural nuances may apply more so to Filipinos around the world?
So the F there in ABCDEF means that the families would start attending the rounds. They also start helping the doctors and the nurses caring for the patients in the ICU. So they would help with bathing the patients. They would help with turning the patients. So they really become engaged with the care of the patient in the ICU. And there is literature that actually shows how beneficial that is, how valuable that is. But as I said, unfortunately, we were not able to do that at all during the entire pandemic. The hardest thing for me during this COVID-19 outbreak is having to talk to the family through the computer, having to tell them, for example, that we have done everything we can. And we were trained how to do this end-of-life discussions face-to-face. We had no training at all on how do you do this with a mask on through Zoom or Starleaf. And that to me was the most challenging part. The medicine part is always relatively easier compared to the social aspects of providing care, not just to the patients, but also to the families and friends of the patients in the intensive care unit.
Thank you, Leo. And then for Homer, this is kind of the elephant in the room for all healthcare workers. Getting tested, whether it be the PCR test, the antibody test, you could have a whole lecture on this, but what is the basic message that you send out to your fellow healthcare workers about these things?
Right now, it's sort of wait and see. Again, ideally, it would be antibody testing, which would show proof that whether or not you've had the disease. Right now, though, we're still they're still being fine-tuned, and then there haven't really been the tests that are as reliable as they need to be. And then we also need to should be able to show that actually having antibodies are protective before you act on that. They are developing tests for neutralizing antibodies. So hopefully, yeah, within a few weeks, or maybe within the next month, we'll have reliable, accurate tests that will help us as healthcare workers to actually figure out whether that bad cold you had in March was actually COVID, even if you didn't get testing then. But yeah, right now, PCR, again, it's just a momentary, just catches you at the moment in time. So certainly PCR is important for diagnosis if you're having symptoms. But otherwise, sort of asymptomatic healthcare workers, yeah, it doesn't really help much. Again, we're waiting for accurate antibody tests, particularly if we have neutralizing antibody tests.
All right. Thank you so much. There are questions on the chat box. Let's go for one question in the chat box. And there's also a question from Facebook. So let's start with the chat box. Dr. Emerson.
Yeah, so we have several questions in the chat box, actually. So I'm going to call on the first person who posted a question. That is Bobby Ray. So Bobby Ray, if you're available, can you unmute and ask your question? I think this question is for Dr. Abiad.
Thank you so much for your presentation. This is very interesting as we deal with recovery of patients and everything. I think there was a lot of talking about the universal masking, and I wanted to ask if that definition of universal masking only included N95 masks, or if it also included cloth masks that the WHO and the CDC are advising everyone else to do outside of the clinical settings.
So definitely, the general term would be face coverings to include, everything, including scarves and so forth. And certainly, they don't provide the same amount of both protection as N95 or even the source control as well. N95 provides more, but they do provide substantial enough so that when both the source and the potential healthy recipient are both wearing masks. So even these sort of homemade cloth masks do provide, if both are wearing them, then that does provide a significant degree of protection that's important outside of the hospital setting.
All right, thank you. So now we have a question from the Facebook messaging. This is from Eagle Eye Broadcasting. Does CBD help prevent dementia? I learned from Cannabis Expo at the Javits Center that 50 milligram a day will help cases of COVID patients. I don't know, a comment on CBD. Anyone?
So, I mean, we don't have any good study to evaluate any of the treatments out there to prevent dementia in general, or even dementia after an ICU admission, it's really going to be difficult to recommend any intervention, including medication, at this point, because there is no scientific evidence behind any of those medications.
All right, so thank you. Dr. Emerson, questions from the chat box?
Yes, I would like to call on Sam, who has a question about testing. Sam, if you are still online, can you please ask your question? I believe this is for Dr. Abiad again.
Hi, Dr. Abiad. My question was, you're making a distinction between the symptom-based strategy and the test-based strategy. So I was just wondering, since you focus more on the symptom-based strategy at your institution, I guess my first question is like, can you clarify what exactly is the, disadvantage of the test-based strategy?
Again, it's sort of like, it's based on your 2 negative nasal swabs. And if you get those 2 negative ones, that's good. But again, the disadvantage is what happens when you get a positive in someone who's recovered, asymptomatic, and is clearly much better. Again, as far as our science, we know that that's in all likelihood that person's no longer infectious. But if you have that positive test, and it's a fresh positive test, it's hard to return them to work. Again, the guidelines, once you head down that testing strategy, then you're sort of stuck retesting until you get those 2 negatives. In which case, like for healthcare system-wise, though, which is of course it's vital to get healthcare workers back to work, back staffing the hospitals as soon as they're non-infectious. That it creates complicated situations then, and what can be unnecessary complications by doing testing that way.
Right. Okay. So, sorry, to, I guess, wrap it up then, someone can be tested positive and still be able to return to work.
Well, no, that's the thing. It's sort of, it's difficult. Technically, yes. Theoretically, if they're really long, they've recovered, and it's been, again, at least 10 days since the onset, especially if it's been longer, they could be able to, but it's hard because the guidelines say that if you've tested afterwards, then the guidelines will say 2 negative. So it's a gray zone. Yeah, technically, if the person's really essential, employee health might say, okay, we recognize the positive, but we're clearing them. But yeah, it's more difficult to do that when the supervisor says, but they just tested positive 2 days ago, and you're telling them to come back to my floor. So it just becomes difficult.
Okay, thank you, doctor.
You're welcome.
Okay, thank you. We have another, it looks like we're extending the time. There's a lot of questions. There's a question from the Facebook page from Joy Arellano. With the morbidity and physical need for physical and occupational therapy post-COVID patients, do you know how long will Medicare pay for the coverage other than the 90 days cap? Will this add more to the present burden of cost caused by the disease? I guess that's Dr. Leo.
Yes, so we don't know the answer. We know that we're probably going into a crisis mode, especially with an increase in unemployment. The most significant fraction of insurance is being provided by employers. So what's going to happen now with the increase in unemployment rate? Who will be paying for the coverage of these people during the pandemic? So I think these are very difficult questions that we will need to be able to address. We think that we have not seen the end of the pandemic. We have not even finished the first wave. So we don't understand why people are already talking about the second wave when in fact we are still in the first wave. We're still seeing a surge of cases, especially in the southern states. So we have to ask these very hard questions about how do we provide healthcare to the people, not just here in the United States, but also in the Philippines and around the world. Perhaps this is the best time to really push for a single payer. We're not going to go there for now, but the answer to the question is it's difficult. But I also wanted, before we end I just want to have a big shout out to UP College of Medicine Class 90 and Class 91, and also Philippine Science High School Class 83 and 84. Homer and I have known each other since we were 12 years old. We went to the same high school and med school. So, but yes.
Thank you. Thank you. In the interest of time, I think we have one more question from the chat box, and then we'll end. Dr. Emerson?
Yes, so I'd like to call on Dr. Melissa Palma, whose question is on palliative care support.
You might have left already, but I'll read her. There are several questions about palliative care, and I just wanted to say that during the entire pandemic time at Beth Israel, where I worked, the palliative care service became part of the ICU service. They were rounding with us. They were trying to get a heads up of which patients will we need help. They were very supportive. And I really think that palliative care needs to be part of the intensive care unit team. Every time that there is a possibility of an outcome that is unexpected, they are the best group of people to work with, not just to be able to help us with symptom management, but also to help us speak with the patients, speak with the family, speak with the friends. So they've been a great support, and we're hoping that their presence become permanent in the intensive care unit from here on.
Well, thank you so much, Dr. Abiad and Dr. Celi, for your invaluable contribution to the Health Forum and our Filipino-American community in general, and Filipinos all around the world, because this forum is being viewed around the world. So before we end, we'd like a few closing remarks from our ambassador, Ambassador Cristobal.
Thank you so much, Dr. Rivera. Well, let me just echo what hundreds of our people made manifest yesterday. We were celebrating 122nd anniversary of Philippine Independence Proclamation, but the focus was precisely to show our thanks, to show our gratitude to all the healthcare workers from our community that have been right there in the front lines against this pandemic. The 40 healthcare workers in the 10 northeast states of the U.S. who have died were a major part of the fatalities that affected our community. As of yesterday, 99 Filipino Americans have been reported to us as having fallen victim to COVID-19. 40 of those 99 were all healthcare workers. Laboratory technicians, 2 of them. 5 were doctors. Physical therapies, there were 3. And the great majority, well, as Dr. Ortalis would guess, nurses. But they were all heroes in the eyes of the world, the authorities of the 10 states in the northeast of U.S. Of those 10 states, New Jersey, New York, Connecticut, Rhode Island, Maine, a bit, and New Hampshire have shown some moderation, in fact, reduction in the infections, in new infections. Massachusetts has been more or less steady, but two, Vermont and Pennsylvania, have been showing increases in the infection rate. And we are worried because Pennsylvania is one of the three states in the Northeast that host the majority of Filipinos. Number one is New York, number two is New Jersey, and number three is Pennsylvania. So we continued through this health forum to advise our people to take all those precautions really very seriously. Opening is what almost everybody desires, but perhaps we can join the reopening, but we should not join the throwing of caution to the wind. We have to be careful, and I do ask our people everywhere to continue to subscribe to the tenets of social distancing and to taking caution as part of our new normal, as part of our routine care for ourselves and for our community. Thank you.
All right, thank you, Ambassador. And now, Marie, just a short announcement, and then closing remarks from Laura.
Yes, thank you so much, Consul General, for supporting our forums consistently. Thank you to our distinguished speaker, Dr. Abiad and Dr. Celi, and of course, our organizers, and most of all, our viewers for your interest in our topics. The next topics, the succeeding topics for the succeeding weeks, will still be determined by the group. So thank you again for attending.
Thank you all for joining our 8th series of the PhilAm Health Forum. Got feedback? We would love to hear from you. Please send us your comments, suggestions on how we can improve our forum, and most importantly, future topics that you would like to hear. And email us at phil.am.health.forum@gmail.com and follow us at #PhilAmHealthCovid-19. Thank you and see you next time. Be well and stay safe.
All right. Thank you so much. Thank you.
Okay. Bye, everyone. Wear your mask.